Patients with classical Hodgkin lymphoma that are candidates for our standard curative therapy have historically been treated with the ABVD regimen. And in the past, this would typically include 6 cycles of ABVD or 12 treatments for patients with advanced stage disease like the one that we discussed in today's case. Fortunately, over the past several years, there have been 2 large studies that have come out that have informed our decision and made the use of 6 full cycles of ABVD a lot less common. One option, which is the one that was selected in the case that we described today, is to use a PET-adapted approach. In this case, patients receive ABVD for 4 treatments, and at the end of their 4 treatments, they have a PET scan. And those people with a negative PET scan will go on to have AVD alone without bleomycin for the remainder of their treatment for a total of 6 cycles, or again, a total of 12 treatments. For those patients, however, that are PET positive, based on the study, those patients would be escalated to a more intensive therapy such as BIACOP. BIACOP is a regimen that hasn't historically been used frequently in the United States, but is commonly used in Germany especially, and likely does have an increased benefit compared to ABVD, although with a significant worsening of toxicity. The other approach is to not use bleomycin at all, and instead to use a novel therapy, brentuximab vedotin, which is an antibody-drug conjugate targeting CD30. In this approach, patients would receive brentuximab vedotin, or BV, combined with AVD for a total of 6 cycles. In this case, we often may check a scan at some point during their treatment, but there is not the planned PET-adapted therapy the same way there is in the first approach. Patients that are receiving ABVD need to be monitored very closely. Although these are often patients that are young and may have limited comorbidities, toxicities such as bleomycin-associated lung toxicity can potentially sneak up on you and may not be easily apparent just based on objective findings. Often patients that are experiencing bleomycin-related lung toxicity may notice subtle changes like difficulty going upstairs, difficulty walking in from the parking lot of your office, or a persistent dry cough. And so any patient that I have that is having even subtle respiratory complaints or a new cough without an alternative explanation, I think very long and hard about whether or not we need to hold the bleomycin in that setting. Again, it's critically important that anybody that comes in contact with the patient receiving bleomycin be monitoring the patients for those symptoms. Other toxicities that we see can include neuropathy. Potentially you could have cardiomyopathy, although this is less common with our Hodgkin patients, as well as myelosuppression and risk of infection. And so it really is important that every member of the team that comes in contact with a patient being treated with ABVD monitor those patients and report to their physician if there's any new complaints. I typically don't include radiation therapy for my patients with advanced stage Hodgkin lymphoma. In almost all cases, patients will either achieve a complete remission and go on into observation, or if not, will need to go on to salvage therapy or some other sort of second-line therapy. And so I typically don't include radiation therapy. The only potential exception would be a patient with initially bulky disease who has some mild FDG uptake at the conclusion of therapy. There are some data that would suggest that there may be some benefit in that selected case. Otherwise, most patients that I take care of that receive radiation therapy for their Hodgkin lymphoma are those with early stage disease, especially those with early stage bulky disease. The patient that we discussed today had an excellent response to their initial chemotherapy. At their interim PET scan, they had a Deauville score of 1, which suggests a complete metabolic response, and so they definitely would meet criteria to de-escalate therapy to the AVD. As we saw in this case, however, obtaining a negative interim PET-CT, while a very positive prognostic marker, is not a guarantee of long-term cure. So those patients still will need to be monitored closely and still have the potential to relapse.